Ptosis is a term that is basically referring to the drooping of the eyelids. Now, there are a lot of causative factors that can result in the ptosis. It can be a bilateral ptosis, it can be a unilateral ptosis, and usually, if it is some sort of a systemic cause that is resulting in the ptosis or the drooping of the eyelids, it can be a nerve damage that can result in the ptosis, it can be a congenital ptosis phenomena. And one of the leading causes of the ptosis is the traumatic ptosis that occurs in a lot of cases of ocular trauma. So over here, we are discussing basically a complication of ocular trauma, which is traumatic ptosis, and it can be even a post-surgical, after a repair, you can observe these ptosis phenomena in a lot of patients. So over here in this section, we're going to focus on the canalicular lacerations. It's again one of the forms of the ocular trauma. Then we're going to focus on the repair procedures that are relating to these traumatic ptosis as well as canalicular lacerations. And then we're going to move on to the complications that can be even the post-operative complications or relating to the surgical procedures, as well as we have the complications that are relating to all of this disease process itself. If we look at the traumatic ptosis, the trauma to the levator aponeurosis or the Mueller's muscles is the main causative factor for the development of this traumatic ptosis over here. To repair, need to identify the levator aponeurosis and to reattach to the tarsal plate is very identifiable over here. General anesthesia is usually given to the patients to treat these cases of traumatic ptosis, and we're going to avoid because it is sometimes quite difficult to perform these surgeries during the local anesthesias. Beware involving the septal injuries if it is occurring. Consider the delayed repair in these cases. Then we have the canalicular lacerations at one hand. So these margins are quite prone to the traumas that are occurring to the ocular structures or that are occurring to the trauma. So sometimes there can be these minor marginal tears over here. On examination, it's quite visible and they're easily identifiable, and you usually refer these patients to the eye surgeons to perform these particular surgeries over there. Having these canalicular system and then basically even this nasolacrimal duct can be damaged in these cases of canalicular lacerations or these marginal injuries over here. The upper canalicular lacerations are quite controversial and the loss may not affect the patient as well. Either repair lacerations or ignore the canalicular lacerations, or stent canaliculus, mini monocular, or repair lacerations. So these are some of the modalities, or these are some of the variants towards the surgical procedures that are devised whenever you have these upper canalicular lacerations. If these lacerations are at the lower margin, what happens is it's usually they need to be repaired, because here there is a lacrimal sac which is basically draining into the nasolacrimal duct, and if this canalicular system is not working properly, it can be quite debilitating for the patient. Repair within 24 to 48 hours is needed, and a stent is usually devised in these cases bicanalicular or monocanalicular, or you have to basically leave the stent for almost a period of 3 to 6 months. So this is the main procedure that you have to follow when you are treating a case of canalicular, or especially a case of lower canalicular laceration over here. 8.0 or 9.0 vicryl to canaliculus are usually given. These are the particular lacerations that we can talk about. It can be involving the lids, especially. It can be the upper eyelids, or even sometimes the lower eyelids are prone to these jagged lacerations. So sometimes it is the blunt weapons that are responsible for these kind of jagged lacerations. If it's a laceration, the weapon has to be blunt in this particular case. But sometimes you have the sharp weapon injuries that are resulting in this sort of a picture. Road traffic accidents are the most common modalities that are resulting, or that are basically showing up unilaterally, as shown in this picture, in this particular case. So there is a lot of tissue loss that you usually observe. Over here, you can see this is a phenomena which is known as hyphema. It's basically the collection of blood in the anterior chamber, and that is basically the most direct evidence towards the ocular trauma. So if you observe on examination this kind of a hyphema, it is quite evident that the ocular trauma has occurred to an extent in this particular case. Explore the wound thoroughly and find all the tissue. So it's very important to examine the case in detail, particularly over here. The options available are a direct repair in this particular case, the tissue advancement in this particular case. For example, it can be the lateral canthotomy. So tissue loss, basically, we're talking about all of the structures that are surrounding the orbit. It can be the musculature, it can be the skin, it can be the fascia. So all of these structures can be at loss or it can be damaged whenever you have the ocular trauma at your hand. The advancement flaps are sometimes modified in case of this trauma, and you have to basically make a rule that you have to replace these all of this tissue loss in layers, because if you want to have a conjugate movement bilaterally, you have to make a delicate reconstructive surgery over here in case of the ocular trauma. The transconjunctival flap and skin grafts are used in these sorts of reconstructive surgeries and vice versa in these cases, but the rule of thumb is basically that you have to replace or you have to repair in flaps over here. The complications that we usually encounter are the lid margin notching. If small, may resolve, otherwise requires a repair. And then we have the lag ophthalmos, which is basically due to scarring or tissue loss or septum into the wound. Try to massage and may need the scar release. Hypertrophic scars are sometimes noted down and they may improve with time. Consider the steroidal injections into 4 to 6 of 52. So these are some of the complications that you would observe even post-operatively in a lot of cases. And sometimes this ocular injuries, it can be the canalicular injuries or the lid injuries or the lacerations. They can even end up in all of these complicative procedures or in all of these complicative sections. The infections are quite rare in these cases, but the tearing is quite common in these cases. The canalicular damage, lid malpositioning, pump failure is very important. Then we can encounter this traumatic ptosis on one hand, which can be myogenic, which is basically involving the muscles, or on the other hand, it can be neurogenic as well. The systemic assessment would include the general classification, which is basically dividing it into local, mechanical injuries involving the globes, destructive globe injuries, and then we have the adnexal injuries involving the tissue. If it's the tissue, it can be the orbit in 25% of the cases, it can be the lids in 45% of the cases, and it can be lacrimal apparatus in almost 1% of the cases. Conjunctival damage in almost 29% of the cases. If it's a non-mechanical injury, for example, a chemical injury, in almost 31.8% of the cases. It can be thermal injuries in case, which is basically almost comprising 45.4% of the cases, radiation 11.4%, and electrical injuries almost 11.4%. The associated injuries along with it are the hand injuries, facial injuries, multiple traumatic injuries in cases of road traffic accidents. The causes of injuries are industrial in 6.1%, sports-related in 16.8%, road traffic accidents in 11.8%, and assaults in almost 9% of the cases. Agricultural causes, it can be again the chemical injuries in almost 14.6% of the cases. Daily activities in almost 41.7% of the cases. So it was the general review regarding the ocular trauma and the ocular injuries and what are the complications in cases of the ocular trauma. So that is the end of this lecture. Thank you for watching sqadia.com.